Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Brian Wood, our medical director, to introduce our guest.
Great. Well, we'd like to welcome Wayne McCormick, who is a professor of medicine here and director of the long-term care department. And Wayne is also a provider in Madison Clinic and a very, very busy provider and geriatrician here. And he will talk to us about HIV and aging. So I'll turn it over to Wayne.
Great. Thanks, Brian. Well, we're going to talk about a topic today that's been of some interest of mine over the past decade and a half or so as I've watched my own patients get older in Madison Clinic. As many of the providers, I think, have noticed, our patients are getting a little bit older, and we're noticing that things are changing kind of outside the realm of our usual HIV care. So what we're going to do to start with today is review current knowledge about HIV in older patients. And for the sake of simplicity, I'll be speaking of people as older, meaning people over the age of 50 or so. So we'll talk a little bit about the epidemiology and the clinical outcomes of using antiretroviral therapy in older people, many of whom have been on antiretrovirals for a couple of decades. We'll discuss aging phenomena, period, and in HIV separately, particularly in regards to what we call immunosenescence, or changes in the immune system that synergize with HIV to harm T-cell function and immune fortitude in older people with HIV. We'll talk about the advent of non-AIDS health-related conditions in older people with HIV infection, and we'll talk about a number of psychosocial issues. Here's some pictures from a New York Magazine article that appeared a few years ago that I think a lot of you are probably familiar with. In our older patients with HIV, things happen, and it probably has something to do with having HIV infection for, in many cases, more than a couple of decades, and being on therapy for a couple of decades. Even with good antiretroviral viral load control, having HIV for that long does something to you that's probably not good. So a lot of these people, you notice, have difficulty with their memory. They've had osteoporotic or hip joint replacement therapy. Their body has changed due to lipodystrophy that they find unpleasant and unnatural. So a lot of complaints accrue among older people with HIV, and we'll talk about some of those. This I put up this chart just to show you the bulge in the epidemiology of HIV infection in the U.S., and to a large extent this pertains to all developed countries, where there's a wave of patients coming that right now the preponderance is in the mid-40s. And I put that up to show you that over time, towards the end of this decade, the next decade, most people with HIV in the U.S. will probably be over age 50, certainly by the next decade. So a lot of the things I'll be talking to you about today will pertain to our practice, if not today, certainly in a few years. Let's go over in near-term objectives of talk a little bit about virologic suppression in older people with HIV, the subsequent immunologic response to successful antiretroviral therapy, and how that impacts mortality. Let's do the good news first. The first thing to notice in older people on antiretroviral therapy is they actually do better than younger people. This top line you see in this chart is the percent of people who have undetectable viral loads after a couple of years of therapy. And you note that people over age 60 actually take the lead. After a couple of years, fully 80% of them have suppressed their viral load to undetectable, and younger people don't do quite as well. So you might ask, well, I wonder why that is, I mean, we think that it's because older people are more adherent to their antiretroviral therapy. But that's just a guess. I'm not sure we know that for sure. And that begs the question, well, why? I mean, if that's true, why are they more adherent to their antiretroviral therapy? We could make some guesses. Maybe it's because they were alive early in the epidemic and saw a lot of their friends die, and so they just take it more seriously. Or maybe older people are just better at taking medicine than younger people. I don't think that's true, though, because I take care of a lot of people in their 80s and 90s. I can tell you for a fact they're not any better at taking medicine than younger people. So for one reason or another, that's kind of an interesting study question. Why might that be? And the success of viral load suppression in older people doesn't actually depend on the base of the regimen, whether they're taking protease inhibitors or non-nukes. The same things pertain. The older people have better rates of viral load suppression than the younger age groups. Unfortunately, that does not result in immunologic reconstitution as well as we'd like to see. Older people do not have a rise in CD4 count to the level that younger people do, even though they seem to do better with viral load suppression. So here the bottom line is people age 60 or older, they do not increase their CD4 count as well as younger people. I'm sorry to say that that also does not depend on the base of the regimen, whether it's boosted PIs or non-nukes. They continue to bring up the rear, and the reason for that is can be summarized in one word, and that's immunosuppression. As people age, forget HIV for a minute, but as we all age, our T cell fortitude changes. Our T cell cell lines, our clusters of differentiation, become more homogeneous, more fully differentiated, less naive CD4 and CD8 cells around to then respond with reconstitution when someone started on antiretroviral therapy. So that there's less thymic fortitude, less thymic reserve simply as we age. People's CD4 counts decline just with age who are not HIV infected. People's CD8 line declines with age and becomes more differentiated. So as a result, there's immunosenescence. The immune system in older people has increased populations of terminally differentiated CD4 and CD8 cells, reduced levels of naive T cells, increased T cell activation. Now this is in HIV. People's T cells remain activated, but terminally differentiated, so there are increased levels of inflammatory markers, increased levels of inflammation with thymic insufficiency, and that's, of course, accelerated in HIV. Now, it's more accentuated in the CD4 line, because after all, that's the target of the virus. But you can see how those factors synergize to produce poor immune function in older people generally, and especially in older people with HIV infection. And that results in higher mortality in part. So people who are older, just over age 55, have a markedly increased mortality compared to younger people, even in the after the advent of effective antiretroviral therapy. So to summarize what we know so far, older people presumably have better adherence and better viral load suppression, but they do not have the same bump in CD4 count that we'd like, and that results in a higher mortality. But the mortality actually isn't due often to HIV causes. In fact, only about 10% of death certificates in older people with HIV show an opportunistic illness as the cause of death. 90% show an amalgam of any number of other conditions, like liver failure, perhaps due to coexistent HCV infection, any number of cancers that we'll talk about in a minute, cardiovascular disease, renal failure, pulmonary failure. And often it's not just one of those conditions, it's an aggregate of those conditions, and I'll talk more about that in a minute. It has to do with multimorbidity. Now, this is a geriatric concept that's basically the sum is worse than the parts, meaning if, let's say, you have coronary artery disease and osteoarthritis and adult onset diabetes and HIV infection, each one of those makes us think that the person's relatively ill and needs special care and may have increased morbidity and mortality. But in aggregate, it's much, much more of an effect on morbidity and mortality than you might think just adding up those conditions. So here's the impact of multimorbidity on function. And you can see that that's not a linear relationship. The more diseases, there's actually an exponential effect on worsening physical functioning. And unfortunately, there's also a worsening effect on mortality, a nonlinear one. So when people appear in senior care clinic with 4 or 5 chronic conditions that might be able to be ameliorated, whether it's osteoarthritis using pain medicine or HIV infection using antiretrovirals, can't be cured. So for conditions that can be ameliorated but not cured with an impact on function or cognition, we think of people like that as having multimorbidity. And for people with multimorbidity, often their survival curve parallels those people with advanced cancers. So we think about things like, well, gosh, maybe we should make sure that this person has a good support system. We should make sure they have advanced directives or power of attorney. Certain things occur to us in senior care clinic when we see people with multimorbidity that probably should be pertaining to our older people with HIV as well, because they're having all of these other chronic conditions separate from their HIV. May be related to HIV, but may be just related to their aging or a combination of the two. It won't surprise you all that people with HIV, even in the antiretroviral therapy era, still have an increased odds of any number of HIV-related cancers, like Kaposi's sarcoma and non-Hodgkin's lymphoma. That doesn't surprise us, but they also have increased rates of liver cancer, lung cancer, melanoma, etc., out of proportion to people who are uninfected. The result of that is just a whole lot of cancer in older people with HIV, both HIV-related and unrelated. It's good to have good oncological help in a clinic like Madison Clinic. And while we've originally thought that this was a marker of aging acceleration in HIV infection, it's probably true that when controlling for all factors, that the age of onset of cancers isn't that different among older people with HIV than in the general population. But that doesn't mean there isn't a whole lot of cancers that occur in older people with HIV. So just because it's maybe not occurring that much at a younger age, it's still a high cancer burden. There's a large increased prevalence of diabetes in older people with HIV. There's an increase in diabetes nationwide, as you see in these green bars, but it's much accentuated among persons with HIV. And you think, well, is that because there's more risk factors for diabetes in older people with HIV? Is it because of antiretroviral therapy? Or is it a gamish of any number of things? Probably the gamish. Nevertheless, there's lots of diabetes. And as a result, there's increased rates of coronary artery disease. This was a study of coronary artery calcium. And the assertion of this particular study was that vascular age is about 15 years higher compared to non-HIV infected people. I'm not sure I'd put it that way, but suffice to say there's plenty of coronary artery disease and diabetes among older people with HIV. And we're getting more and more used to juggling a lot of medicines among older people with HIV. This is a chart showing that the non-HIV meds tends to proliferate and grow among older people with HIV. So on your right, you see people age 65 or over taking a whole lot of meds besides their antiretrovirals, and that's a pharmacologic challenge. Looking at drug-drug interactions between antiretrovirals and non-HIV meds, it can be a bit challenging to juggle those different medicines. Among older people with HIV, they have higher rates of HIV-associated dementia, but also higher rates of cognitive problems that might not meet the criteria for dementia formally. So more subtle things are often complained about among older people with HIV that may impact their day-to-day function, even though they wouldn't formally be diagnosed with dementia per se. Many older people with HIV are testosterone deficient among men, and menopause occurs at a younger age than in people who are not HIV infected, which then leads to loss of bone mineral density. The odds of having a low BMD is much higher among HIV infected people than non-infected, and there's an increased fracture rate. It's not just the BMD, there's actually more fractures in older HIV infected individuals. And as I mentioned before, some of these people have lived through the early phase of the epidemic. It may be that a lot of their friends have died before antiretroviral therapy. And people who are getting to their 50s and 60s start to lose their parents and other family level support. They may have been on disability for quite a while and have financial issues. So it brings to the fore once again that we should be thinking about power of attorney for individuals and maybe working on their directives. So I've practiced through all these eras of the HIV epidemic. I was a resident early on in the epidemic before antiretroviral therapy and experienced the joy of the onset of antiretroviral therapy that was effective during the last decade or so. But now we're entering this chronic disease era with this wave of older people coming towards us in the next decade or so, and we'll probably be managing a lot of things besides their HIV disease in the future. A lot of people, HIV will be the least of their problems. There'll be all these other comorbidities that HIV specialists will be starting to manage more and more of. So in conclusion, in the U.S., HIV is increasingly an older population. Compared to younger people, they have a better viral load depression with antiretroviral therapy, but less immunologic boost and a shortened survival. The comorbidities will be the main things we're working on in the future, and I want to reemphasize the psychosocial issues and things that pertain to multimorbidity. Certainly I have patients in their 70s who were doing great on antiretroviral therapy, don't seem to have much else wrong with them. But then I have people in their 50s and 60s who have a lot of comorbid disease. Those are the ones I worry the most about, co-managing all those things with their HIV illness. So with that, I'll leave you with these resources and leave them up on the board for information about HIV and aging guidelines that are part of the NIH guidelines, our work with the American Academy of HIV Medicine and the American Geriatric Society, and a summary report of activities from a consensus project that a number of us in the Pacific Northwest and elsewhere have worked on. And also a piece at the bottom there about managing people with multiple chronic conditions or multimorbidity, regardless of what those diagnoses are. So thanks very much.